Good morning, everyone. So we are going to start a very pertinent session related to all of us in cataract practices, and that is how to graduate to be a cataract refractive surgeon. So in the evolving times, the patients are demanding, and with the evolution of so many intraocular lenses, it seems the need of the day to be able to offer our patients the best of vision at all distances. So without any ado, we'll start the session. Our first speaker
1 minute. Why don't all of you all come and sit in the front? I mean, we are a small cohesive group. You come in the front, you can ask your doubts and questions. The last row, people all come to the first row. It's not my thing, huh?
Our first speaker is going to be Dr. Rishi Swaroop. He's the director of Swaroop Eye Center in Hyderabad. He has a lot of international courses that he's taken in ESCRS, ASCRS, and he's a prominent name in cornea as a specialty. He's done his graduation, the fellowship from LVPI, and he's an expert to tell us how to set up the selection criteria for the presbyopic IOL patients.
Hello. Yeah. Thank you. Abhijit, just a small correction. I did my fellowship from Shankar Netralaya. I was a consultant at LVP. Yeah. So at the outset, I'd like to thank Dr. Parul for involving me in this lovely course, which is in Hall A. So we're getting prime property. I think it's a very pertinent topic, and all of us are dealing with patients who are in this category, who are presbyopic, and they want cataract surgery, but they also want to get rid of glasses. Irrespective of a place of practice, I think the times are evolving in such a way that patients expect more from cataract surgery, and we have to either deliver it or at least be ready to deliver it in the near future. So whenever we're evaluating a patient who has a potential of being one of our cataract patients in the presbyopic group and possibly needs a refractive cataract surgery, we have to look at them slightly differently from a regular cataract. So I will just touch upon the things that are slightly different from what you would anyway look at in a comprehensive examination. So we'll go in the systematic way of history, examination, diagnostics. In history, we look at age, occupation, visual requirements, pre-existing refractive errors, personality, patient expectations, specifically night driving. Examination, ocular alignment and external eye, anterior segment, what things to look for, posterior segment pathologies, and specifically what type of cataract are we dealing with. Diagnostic tools have become very, very important, and they really help us deliver that little extra, and especially in avoiding the patients which would not be ideal. You can pick up some very, very important findings with the diagnostic tools, which will help you in your case selection. So I think this history is probably the most important thing when you're dealing with a premium refractive surgery in which can do a presbyopic correction. You want to understand your patient's visual requirements. So these are just some scenarios I've thrown there, and these are all scenarios we come across in the clinic. You have people who need to look at screens for several hours in a day. You have people who have, so these are intermediate vision requirements, people who don't have any near requirements, who are just looking at distance. You have people who need to do knitting, some people who love to read, taxi drivers who might have a requirement of night driving. This picture I've put is of a DJ who has got a cataract at a young age. So she's a young person, needs vision at all distances, but he's dealing with LED lights. She's a DJ in a disco. So she is likely to have the same visual phenomena that a night driver might have with the LED lights. Then you have a lawyer who needs to do computers, but lawyers are people who are relative contraindications for all refractive surgeries, so to say. Then you've got, so I mean, I'm not going to cover which lens to choose in which of these patients. I'm sure Dr. Parul and the other speakers will cover that. But these are things we have to keep in mind, and I think this is a very, very important slide because you have to pay attention to a patient's visual requirements when you're selecting the lens and the type of surgery. Pre-existing refractive error is again something which is often overlooked. So if you have a low myope and he or she desires a refractive cataract surgery, if you give them a multifocal, these people are used to a very good unaided near vision. You know, they just take off your glasses and you can see very well, especially if they don't have a cataract yet or a very mild cataract with which they have N6 unaided near vision. You put a multifocal or a trifocal in their eye, they will not enjoy that near vision as good as their unaided near vision was, and they will always be unhappy. So this is one subset where you have to be very careful in selecting your lens. High myopes, again, because they'll often have associated retinal pathologies, and you know already the retina is weak, and then if you're going to split the light and reduce their contrast, they may not be happy. So again, you have to look at them carefully before you select. Post LASIK, post RK, the lens power calculation is challenging. You may not end up with a spot-on emmetropia, and if you put a presbyopia correcting IOL which has low tolerance for emmetropia, you may end up with an unhappy patient. So again, that's something which you need to keep in mind. Astigmatics, we do have astigmatism correcting presbyopia IOLs, but you have to make sure that you choose those, or you have to do some sort of a procedure like an LRI or an opposite clear corneal incision. Pure presbyopes are probably good patients for these lenses. But again, they are used to good emmetropic distance vision, so you have to hit emmetropia spot on. Hyperopic presbyopia is actually the best candidates for these cases because their unaided and distance vision is not good, so whatever you do for them, they're usually very happy. The second important thing to look at is the personality. I think the timer isn't working. It's been at 3 minutes from the beginning, so I'm not getting an idea of my time. So personality is very important. If you have a patient who's a type A personality or even a type D personality, I think those are a little risky patients to do these kind of patients because they will not be happy. Perfectionists, people who ask a lot of questions, take up 15-20 minutes of your OPD time, these are patients who are going to ask you questions after surgery also. So, and people who expect the world, and you're not going to be able to satisfy them in any way. So better to under-promise and over-deliver. Avoid such patients or try to deviate them towards some more forgiving kind of a lens. Night driving, again, I think specifically this has to be kept in mind because, you know, you have all these visual phenomena that we know are there with many of the presbyopia correcting IOLs. And even EDOF lenses are not free from them, even though the company guys might tell you. So please be very careful when you're selecting people who do night driving. Specifically tell them they'll have. Now the night drivers are two types. One is occupational night drivers and one are occasional night drivers. So those who are occupational night drivers, you must avoid. Occasional night drivers, you tell them the risks, and if they're okay with it, as long as they understand it, it may be okay to go ahead. Examination of the eye, look at the eye before you look at the eye on the slit lamp. So if the patient has a squint, very often, you know, dense cataracts will end up with a sensory exotropia which will autocorrect after you've done the surgery. But if it doesn't, then maybe this patient may not be ideal for a presbyopia correcting IOL. If you have a squint, make sure you're not missing out on an amblyopia. Specifically look at the lids and ocular surface. You know, everything has to be right. There should be no other attendant pathology like a trichiasis or a dry eye or exposure keratopathy. All these things will cause a compromise in your outcome. Dry eyes are something which are often missed, and then you'll have patients who are unhappy because of the dry eye, but they would have spent a lakh on the cataract surgery, so they'll blame everything on the surgery. EBMD, epithelial basement membrane dystrophy, is something which is often missed in the clinic. Many people miss this. These are these little map-like figures you'll see on the epithelium. We often think they are irrelevant, but these patients often have surface problems, and this can affect the vision as well. So look for this carefully. Look for other degenerations. Pterygia, very small atrophic pterygia may look innocuous, but if you do a topography, you'll see this kind of a flattening ahead of it, and that can cause a significant astigmatism, irregularity in the cornea, and unhappy patients post-op. So look for topography, especially in these patients. Angle kappa, angle alpha, can I take another minute? Angle kappa, angle alpha, again are very important because if your lens is not well centered on your visual axis, you will not have a happy patient. The dense cataracts, intumescent cataracts, if you have a capsular integrity loss or a zonular integrity loss, all these patients you have to be very proficient to be able to put a presbyopia correcting lens, because basically the lens has to be perfectly centered. So as long as you're able to do that, it's perfectly okay. But if you think you can't, then be careful about choosing such a lens. Posterior segment pathologies, macular pathologies like epiretinal membranes, any macular degenerations, dystrophies, glaucoma, all of these are contraindications. Asteroid hyalosis is the relative contraindication. You have to explain to the patient and take a calculated risk. Biometry is something we must look at, especially if you have extremes of axial length. Post-refractive surgery cases, you have to make sure that your biometry is spot on, so make sure you use the right formulae and right website, etc. has to be used for using post-refractive correction. Silicon-filled eyes can end up with errors, so specifically make sure that you're using an optical biometer. Sometimes if you have a dense white cataract, you won't get an optical biometry. In such a case, you have to probably avoid using a multifocal or use it as a two-step surgery. Topographies are very important. Look specifically for irregularities, and if you have them, avoid these lenses in these patients. OCT, I think, is an invaluable tool. All patients who are going for these premium lenses should have an OCT. So often you'll pick up macular holes, epiretinal membranes, vitreomacular traction, and these are absolutely patients who are not good for presbyopia correcting IOLs. So look for them. If you can't see the fundus, do a B scan. This is a B scan showing optic nerve cupping, and if you miss this, you'll have an unhappy patient post-operatively. So the take home is thorough evaluation of all patients is a must. And if you do a proper history taking, good examination, and look for the diagnostic clues with appropriate diagnostic tools, these are as important as a good skilled surgery in delivering a happy patient and a happy doctor. Thank you.
Thank you, Rishi. We'll take the next speaker, Dr. Parul Sharma. She is the Director Ophthalmology of Max Group of Hospitals, Delhi and Gurugram. And she has 20 years of experience in refractive and cataract surgery, and she's changed the way the world is looking today at corporate ophthalmology.
Thank you, Dr. Abhijit, and a warm welcome to all of you. And I hope this instruction course is useful to you at the at the end of the session. And as Rishi said, that cataract is not just restorative. It's perhaps one of the most common, I would say, refractive surgeries now for an anterior segment surgeon. So we have all seen the evolution of the presbyopic IOLs over a period of years, and the principle remains the same, that it's a simultaneous vision where your one eye is in focus and the other, which is not in focus, is the suppressed, and that's how you get simultaneous visions at all levels. But halos, glare, dysphotopsia remains a problem because of these out of focus images. Now, despite so many evolution and despite so many promising IOLs, sometimes our patients still, why all cataract surgeons are not doing 100% presbyopic surgeries, because sometimes the patient will complain of problem in the visual acuity, sometimes the contrast is a problem, there could be an occasional glare and halos, and you spend so much time and effort and money, and the patient says that, nah, in our North India they said maza nahi aaya, So this is a challenge for the cataract surgeon, that how to do all your cataract surgery as a cataract refractive surgery. So we started from the era of refractive multifocal, where the refractive rings caused the simultaneous vision, but then it had its own limitation in terms of loss of contrast sensitivity, being pupil dependent, being very sensitive to centration, and hence the evolution to the diffractive multifocal IOLs. Now here the principle is to use diffractive rings, the physical steps on the IOL, which creates the multifocality, dividing the light into various zones, and there have been a lot of modifications where we've gone from apodized to non-apodized to changing the height and width of the ring, and the aim is always be able to give you a continuous range of vision with a better utilization so that the energy is better. So just an example of how even the trifocals have evolved over a period of time, and different companies promise you different technology. So, you get confused when you're starting with presbyopic IOLs. There are so many options, and every other day the MR would be sitting in your OPD, and every MR's lens is the best. So this is just to give you an overview that these are the common diffractive trifocal IOLs, and the other are the extended depth of focus or the extended range of vision CRV kind of lenses. So just to know that this is what we have in our hand as a spectrum. So I've picked up few common lenses to give you an understanding on how they work. So for example, Alcon Panoptic works on a diffractive trifocal technology. It uses the fourth zone it has combined into the first to give better light utilization, and hence it's called an enlightened optical technology to give better contrast. It gives excellent near vision and also in distance and intermediate. So similarly, Zeiss also works on the trifocal principle, which has two distinct additional focal points for intermediate and near distance. And most of the lenses are now, by the virtue of how their diffractive rings are in the center, are becoming more and more pupil independent. But of course, in the pre-examination, as Dr. Rishi said, we do also have to look at pupil size to see how it works in the mesopic conditions. Another popular lens, it's by J&J. It's a synergy. It's called synergy because it combines what they have learned from their previous two lenses. So they had a multifocal refractive and they had a symphony, and we know the problem with symphony, how our patients could not really read N5 and very close, and there was a top up or a micro myopia advised in other eyes, the micro monovision. So they've combined these two technologies to give a continuous range of vision, and they have also added something called as chrome-li, which is reducing the chromatic aberration to improve the overall contrast sensitivity. Then there are some new lenses which has come as hybrid lenses. Basically, the outer platform is a refractive platform for distance vision, and the center is an aspheric surface for near and intermediate distance, also promising continuous range of vision. Another lens is the mini-well lens. This has caused spherical aberration in the central 3 mm of IOL, and we know with the spherical aberrations, if the light are focused at different foci, it just gives you an extended depth of focus lens. So, and again they have modifications. If they feel that their lenses are not doing well for near, they have a mini well proxa for the non-dominant near vision, and asking for combination of their regular and proxa lenses. The new kid on the block, a very popular lens by Alcon now, is Vivity. It works on a different principle of X-wave technology. So here there are two smooth transition elements in the center zone of the pupil, and within this zone there is a 1 micron elevated plateau. So all this stretches your wavefront and shifts the line onto an extended focal length. So the advantage of Vivity is that it doesn't have those multiple diffractive rings, so it doesn't give that much of glare and halos. It's just got a central bump which you can see on the lens, and this is also working very well for distance, near and intermediate vision. Because it doesn't have diffractive ring, it doesn't decrease the contrast sensitivity. So one thing which you can be very sure of with a Vivity lens is that your distance vision is not going to get compromised, so you're not scared that the patient will have problem. A safer bet, wherever you cannot use presbyopic lens, is now something called as enhanced monofocal. So you have an Eyehance, which is a Technis J&J platform, and the Ray 1 IOL. Basically, it's a refractive lens with a continuous power profile created with higher order spherical aberration, anterior surface. The power is increasing continuously from the periphery to the center without any steps or zone. So this looks like a monofocal lens. There are no rings, there is no central bump, and it just simulates extended depth of focus by the virtue of how the power is distributed over the lens. It gives you distance and intermediate, doesn't really give you a close read up. So if your patient doesn't fall into the category of other presbyopic IOL for various reasons, ocular reasons and other reasons, then this is a safe bet which you can choose from. Last but not the least, our old gold, monovision standard. We are talking about cataract refractive surgery, and if the patient is not falling into the category of any kind of presbyopic lens, then, and if the patient is also keen that he wants to decrease the dependence on glasses, then we've always done this. Choose your dominant eye by looking, which eye is dominant, correct them for distance, and the other eye, depending on what he wants, near or intermediate more, you leave a residual of 1.5 or 2.5 depending. So I would say, since we are doing this session for, general ophthalmologists who are transitioning to cataract refractive, it's very important to choose the initial cases. You don't want to have a bad, unsatisfied patient and then you get disheartened and don't do more of these lenses. So choose a hyper presbyopic. These are extremely grateful people because, they've already been struggling with their plus for near. Whatever comes out, even if there's a small residual error, they're extremely happy patients. Choose patients with less than 0.5 astigmatism because most of the lenses are forgiving for that much astigmatism. Anything more, Dr. Harshul's talk is there on how to manage astigmatism for presbyopic IOL. You will have to go to toric and other means. So that's a transition. First be comfortable with presbyopic, choose lesser astigmatism and go with that. Preferably bilateral because the neural adaptation is always much better. If you do one eye presbyopic or diffractive lens and the other is not, there is a bit of struggle in the neural adaptation. condition. And of course, as we know that the ocular screening, like two things which every presbyopic IOL or a premium IOL planning needs is a corneal topography and a macular OCT. So you create a cataract package the way we charge our biometry, incorporate topo and OCT in it, and your optom should know that a presbyopic IOL and premium IOL need that kinds. So now, just with that kind of overview that you have that many lenses options, which lens would you want to choose from? So as pointed out earlier, it's very important to understand the patient's lifestyle, work, need, understand their comfort for paying. See, they are paying more, and if they are not 100% satisfied with what they get, you're going to have a very unhappy patient and you'll spend a lot of chair time. So never push a patient beyond their means. We have Indian lenses also, we have other options that we have discussed, go for that. Establish a predictable lens. Every MR will come and tell you my lens is the best. So what you do is talk to your colleagues who've been in presbyopic IOL. I did that few years back when I transitioned to this stage. Talk to your colleagues, let them make the mistakes and then you learn from their mistakes. It's always better that way. So look into their lifestyle and profession. Be very cognizant of the fact that what all requirements they need. The sudden change now, see earlier when we did refractive IOLs where we started from many years back was about distance and near. Now you'll realize, especially with the lockdown COVID times, 90%, 80% we are on digital platforms. There's a lot of LED light which we use. So these also become challenging situations for the lenses to adapt to what kind of distances we want to work to. There's a lot of emphasis now in evolution of intraocular lenses on intermediate distance because there's a lot of work being done at that level. So, how to choose the lens when you go back to your OPDs, please make a questionnaire format. There are some standard ones out there. Even the company people give you, the patient sitting in your OPD while he is getting worked up can fill those forms as to what his visual requirements are. Depending, I'm not going to go into detail here because, after the end of the instruction course, we will discuss that what is the patient's requirement. For example, somebody's near work is more, or if distance is more, different clinical situations is what we will decide and help you to make a lens. And of course, type A personality who don't want to compromise on their lenses or, the top-up glasses will not be the ideal patient for presbyopic lenses. So these are the conditions which we will be discussing in our post-talk session as to different situations and which and when and how to choose. So, the lenses are still, evolving. We are still to get the best ideal lens, but the idea of this AC is to give you a sense of what best we can do in the current armamentarium and how to give best results to your patients. Thank you.
Thank you, Dr. Parul.
One sec, let me introduce you, Dr. Abhijit. So, Dr. Abhijit is a prolific, high-skilled surgeon from Mumbai. He practices in Borivali as Soham Eye Center. He has a very keen interest in academics and research is always keen to learn, always keen to get the fanciest of equipments, has multiple, presentations in conferences abroad. And today, he's also went an extra length. One of our speakers had to back out for some this thing. So he'll be covering 2 talks. He'll tell us how to do proper biometries and also the surgical pearls for presbyopic IOLs. Dr. Abhijit, thank you.
Thank you. So we are talking about pearls in biometry. Optical biometer now is an essential for all presbyopic IOLs, but immersion biometry still is an integral part of our practice, especially for the dense cataracts. Immersion is very accurate, but in the era of multifocal and multifocal torics, Hagees wants ACD and Holaday 2 or Barrett or Olsen, they need more ocular data and the modern machines are capable of doing that. So how do we improve our outcomes? So these are a few acts of commissions and omission that we do very often during our OPD. And most of the times it's hurry on the from the optoms or incorrect labeling of IOLs or no IOL or incorrect IOL on the day of the surgery. Please don't do indentation biometry. Immersion would be a better option. You should look at the echos. Do not perform keratometry after touching the surface of the eye or if the surface of the eye is dry. These are the other important things like not checking the steeper axis before the incision or altering the A constants as per the surgical results over a period of time, and especially transcription errors in the era of Barrett online toric calculators. How many of us check the lateral canthus level when we are doing an optical biometry? This is very important because a small head tilt can give rise to a wrong reading on the toric IOL front, and you would be marking them with taking the lateral canthus into account, and you will end up with the error of placement of the IOL. The recommended IOL formula, there are plenty. So we used to follow the axial length criteria for such a long time, but over a period, Barrett or Hill RBF is very good, and it covers most of the axial lengths. And in post-refractive surgery also, Barrett True-K or the True-K toric works very well. We have newer machines which calculate the posterior corneal curvature and give you the actual total K, and even that works well in the post-refractive surgery. You have plenty of online formulas like the Barrett entire suite. You have the ASCRS multiple formulas wherein you can calculate on different platforms and then decide which lens you want to use. Dry eye treatment is very important, because if you see, this is a patient who was on the left hand side is without the dry eye treatment, showing an IOL power of 21. On the right hand side, it's showing a IOL power of 20 once the TBUT had improved. You need to validate your machines and calibrate your machines and validate your readings. So the most important part of validation is to remove the outliers of your readings. And here you need to go into the standard deviation drop-down menu of your biometer and go into certain details and find out those flags and remove it and get down to a minimum standard deviation. There are plenty of such things, and each biometer would have different validation criteria, and you should actually avoid outliers by whenever you are transferring data from the A-scan to the biometry or from the biometry to the online calculators, double check those readings. Again, the head tilt, as I said, is an important cause of a wrong steep axis. Posterior staphyloma's optical biometer definitely works better, and it's preferable to use at least 2 machines for the K-metry to compare your Ks and see to it that they are accurate. As I said, remove bad images from the biometer. IOL master would have different ways of validation criteria, like you would have these exclamation marks against certain readings. You need to check those out in your drop-down menus. You need to refine your axis to a standard deviation of less than 3.5 degrees by choosing the right readings which are closer to each other. Look at the pupil barycenter, especially in presbyopic correcting IOLs. It's indicative of outlier. So if the dx plus dy, that's the distance from the center of the pupil to the visual axis, it will give you as a dx plus dy. If it is more than 0.6, preferably not to be used. These patients are not to be advised presbyopic IOLs. Angle, kappa, alpha, all these things are available, but as basic general ophthalmologists, we do not have fancy equipment to calculate those. So it's a good thing to center the IOL between the 2 Purkinje images, the first and the second, and that should usually help you. Higher in hyperopes compared to myopes, so be careful in these high hypermetropes whenever you are treating. So here's an example of biometry wherein we have an incision at 180, which is the normal thing we take, and it's showing a T2 model. But a simple change in the incision at the steep meridian is changing your model from a T2 to a simple plain IOL. So here is an example in which you would have different IOLs there, and in which IOL are you going to choose which particular refractive error or the spherical equivalent. So traditionally, trifocals try to go either exactly emetrope or slightly hyperope. So the closest hyperopic to emetrope or emetrope is what you would aim at. While in EDOFs it would be different, in a lens like Vivity it would be different, like in a lens like Synergy it would be different. So go by the recommended criteria by the company initially, and then later on try to refine your outcomes. Now here is a patient who has a right eye toric and a left eye non-toric. So here you need to find out which instrument was used for taking the K-metry readings. So here, unfortunately, one eye was fed with the auto-ref K readings and the other eye was fed with the optical biometry readings because the patient was uncooperative and he had not, the optom had not told us. So these are the outliers which you need to find out. High hypermetropes or high myopes, you need to use different formula and then see which formulas are coming closer by. Like here, example, we are using the Barrett or the Hagees or the Hill RBF, Hoffer-Q and the Holaday. So you need to decide which in your hands is giving you a better option after deciding your outcomes. Difference in topography readings is very important. Like the same patient is giving me 2 different IOLs at 2 different settings because he has come after around 6 months. And when we did the topography, it's showing a frank keratoconus in both the eyes. To summarize, optical biometry is important with newer formulae, premium IOLs, but not indispensable. Please use immersion. Doing biometry before IOP or dilatation or touching the ocular surface is extremely important. Analyze your biometries over a period of time. You would set in a protocol for yourself and that is going to really help you in the long run. Please take the flags seriously. Head tilt is to be eliminated during biometry, keratometry or during toric marking. That will also help you increase the outcomes, improve the outcomes of the toric IOLs. Thank you. This is just an example, this is just an example of the Varion in which we usually go by the spherical equivalent, but actually the spherical equivalent, if you see the green, right hand side green box, is divided into the cross cylinder, and this is very important when you are analyzing and deciding which IOL to put in these kind of patients. Thank you. Can I take my second talk?
Yeah, please go ahead.
These are a few surgical pearls for presbyopic IOLs. We need to understand how to give the maximum benefit of presbyopic IOLs to the patient, and surgical technique and what we follow during surgery is very important. Pearls develop over a period of time. Incision, rhexis, pupillary centration, small pupil, capsule polishing, final IOL placement, these are the most important points. Last but not the least is a good phacoemulsification technique as well. Incision, preferably you need to start planning your position. So your hands should be relaxed, because if you're going to have a cramped up position, you're going to be lifting up the lip, you're going to induce an SIA. Double incisions, as in you've had a premature entry, you're coming out, making another entry is going to change your SIA. So that's again going to change your outcome. Use new blades, that's going to give you consistent results. You need to have good square MICS incisions of less than 2.4, because your centroid SIA is going to be around 0.1 with these kind of this ones, and more predictable outcomes. With the CCC, the corneal rhexis markers or the Veris or the Varion is something that you should start off with, because estimation of your 5 or a 5.5 may not always be right and may not always be centering around the Purkinje images. I prefer doing the rhexis around the visual axis on the Varion, but you can do it around the center of the pupil as well, but slightly nasally. You need to see to it that 360 degrees coverage of the IOL edge happens, because that's really going to center your IOL well. An inadequate coverage or a decentered CCC is not acceptable in presbyopic IOLs, though it happens in everybody's hands once in a while, because it over a period of time decenters the IOL and causes those kind of issues. Definitely flax, the CCC is very well centered and it's consistent with the size, but that's perfect, not a problem. Capsule polishing, again, we used to do a lot of anterior-capsular polishing, but over a period of time we've known that it's not really important. Most important is the posterior capsular polishing, because you need to remove off those Elchnik pearls. I am doing showing it here with a bimanual on this, but that's okay. You can do it with a hydro cannula, you can do it with anything, but please polish the PC well, because presbyopic IOLs, you're charging a lot, and if the patient comes back with a PCO within just a few days or months, usually cribs about it quite a bit. You need to check your eye tips pretty regularly, because over a period, whenever you're cleaning them, you do get ragged edges on the IOL tips, like what I am doing out here, and you tend to get a PC tear. And in case you do get anything of these sorts, please convert it into a posterior capsular rhexis, and in that case you can easily put a presbyopic correcting IOL in spite of the rent out there. So here I'm using a capsular rhexis forceps, microcapsular rhexis forceps. I'm pulling up the capsule up because there's no vitreous out there. I've used a dispersive viscoelastic to do the PCCC, and I'm going to complete the PCCC out here and then put in the IOL there. So though this is a toric IOL which I have put, you can always put in a presbyopic IOL there as well. These plaques are also important. They can be easily removed. You need to be very careful or have a good microscope, but you can peel these plaques off the PC. If there's a gap which is left between the plaque and the IOL, the epithelial front can grow behind and cause PCO, early PCO. And if there is a doubt of any zonular dialysis, it's always better to put a CTR. So even if there's a loose bag, during your polishing you realize that the bag is moving slightly, there's no harm in putting in a CTR, because it's going to prevent the entire IOL back complex from getting dislocated anywhere. The IOL placement is very important here, and you need to center it pretty well. For the toric IOLs, you can use a needle to do the markings on the slit lamp, stain them with the trypan blue stain, and they stay there pretty well, and you can actually have a very sharp marking there. See to it that your wound leakages are not happening, because that can change the position of the toric IOLs. The center of the pupil and the first pupillary image, the angle kappa, is very important. So what I do is I usually try to center it between the two Purkinje images, and that's usually the best possible estimation of the visual axis. And please remove the viscoelastic behind the IOL, because that can change your immediate post-op outcomes, as well as it's going to prevent secondary surgery in the immediate post-op period as well. And as I said, obviously a good phaco technique is very important. Small pupil, a boon or a bane, we don't know, but anything less than 2.5 millimeters, please tread with caution. Manage the pupil without causing a sphincter tear. It would cause an atonic pupil, and if a presbyopic IOL is put in such cases, it's not going to really work to its optimum. Avoid hooks. You can use a B-hex or a Malugin ring. That's very safe on the pupil. Have faith in technology and conviction in your advice and surgery. Thank you.
Thank you, Dr. Abhijit, for such a lucid explanation on things. I now invite Dr. Harshul Tak, our young, bright ophthalmologist from Jaipur, founder of Rawat Eye Hospital. Dr. Harshul is not only an efficient and skilled eye surgeon, but you've seen his extracurricular life beyond ophthalmology, how he's got people on to doing different things. So we call him the Virat Kohli of ophthalmology world, doing everything, surgery, sports, you name it. So he's going to be talking about how to deal with astigmatism patients in presbyopic IOL forum.
Good morning, everybody. At the outset, I'd like to thank Dr. Parul for making me a part of her wonderful course. So I'll be speaking on how to manage astigmatism along with presbyopia. How do you plan for astigmatism correction while doing cataract surgery? So Dr. Parul nicely showed all the options which are available for trifocal and EDOF IOLs. But we all know that treating preoperative corneal astigmatism is crucial for patients with trifocal IOLs, because it has been reported that if we have residual astigmatism more than 0.75 diopter, it leads to deterioration of visual quality. Of course, subjective perception of halos and glare after multifocal IOL is correlated with the amount of the post-operative residual astigmatism. So recently we have availability of trifocal toric IOLs which compensate for different level of pre-existing corneal astigmatism after cataract surgery. So the studies have shown that toric version, they not only distribute incoming light into 3 foci as in the trifocal IOL, but also simultaneously they compensate for the flattest and steepest meridian of the cornea in these 3 foci. So whatever presbyopia correcting technologies we use, if we don't address this astigmatism, patient will not have satisfactory uncorrected vision and spectacle independence after surgery. So, as Dr. Rishi mentioned that before going for any these premium IOLs, multifocal, trifocals, it's very important that firstly we manage and stabilize ocular surface, especially if patient has dry eyes or if patient has pterygium. So we need to take care of that ocular surface before going ahead, because all the measurements, they become affected because of these corneal conditions. So to accurately measure corneal astigmatism, of course, we need optical biometers. So we have plethora of optical biometers right now available with us, OA2000, IOL Master 700 or Anterion or Lenstar, whatever you decide. But biometry is the key and it has to be accurate. So axial length, of course, as Dr. Abhijit also mentioned, that if you don't have optical, at least you should use immersion biometry, and if you have optical biometers, it's good. So coming to keratometry is the main important measurement to calculate the toric IOL, which is required to correct astigmatism. So we can always enhance accuracy of toric IOL calculation by taking multiple measurements. So we should try to employ at least 2 devices which are based on different principles. Like if you use the AutoK, you try to use Scheimpflug based or the optical biometers. It will definitely increase the accuracy, and we should have consistency in the readings whatever we are taking. And whatever keratometry you are doing, do it before you put any drop over the cornea. So a word about posterior corneal astigmatism, which is, as Douglas Koch showed in 2013, the importance of posterior corneal astigmatism, which plays very important role. We all should know that the posterior steepest meridian is almost always vertically aligned. So what it does is, it creates an against the rule astigmatism. So if we are measuring with the rule astigmatism, we need to undercorrect, and if we are treating against the rule astigmatism, we need to overcorrect. So if you look at this slide, it clearly shows that the anterior corneal surface, it behaves as a plus lens. Anterior cornea can have with the rule, against the rule, or oblique astigmatism. And with age, it changes from with the rule to against the rule. But posterior corneal surface, it's almost always against the rule. It behaves as a minus lens, and it stays against the rule with age. So coming to the toric IOL calculation, so once you have the flat and steep case, so the toric calculator, Barrett toric calculator, it has proprietary like mechanism to compensate for the posterior corneal astigmatism. So you feed in the flat K, steep K in the calculator. If you can see here, this patient had 44 K at 180 degree and 46 at 90 degrees. So patient had with the rule astigmatism of 2 diopter. But if you look at the final calculation, it shows that patient should receive a toric IOL which corrects 2.25 at IOL plane and 1.5 diopter at corneal plane. So it has come down from 2 diopter, which was with the rule, if you look at the anterior cornea, only to 1.5 diopter. So whenever we have with the rule, we need to undercorrect, and if we have against the rule, we need to overcorrect. So this is a very good slide from Dr. Savini's studies, which showed the how we can calculate the total corneal astigmatism using the Scheimpflug technology. This is a slide which shows that if we use only SIM-K, that is only the anterior surface corneal astigmatism, with the rule, we tend to overcorrect, and against the rule, we tend to undercorrect. But if you use the total corneal refractive power, the results are very good and near to ametropia. So after accurately measuring the keratometry and axial length, now we need the IOL power calculation formulas so that we can get the magnitude of IOL power, the toricity and axis. So the Barrett toric calculator works wonderfully in almost all the cases, so which is freely available online, and all the biometers, of course, have incorporated Barrett toric calculators. It takes into account both the effective lens position and posterior corneal astigmatism. So these are the different IOLs, trifocal toric IOLs, which are available, like Restore, Technis, Symphony, Physiol, AT-LISA. So all the trifocal, multifocal IOLs have incorporated astigmatism along in their models. So coming to the methods of toric IOL alignment, first we need to do, either we can do manual marking of the cornea for reference axis, we can use slit lamp or bubble marker or pendulum marker, or we can use nowadays image-guided systems which are Varion and Callisto, or we can also use intraoperative aberrometry like ORA and HOLOS. So coming to how to use the slit lamp to mark the reference axis. So patient is sitting straight on the slit lamp, we narrow down on the, we tilt the slit beam horizontally, narrow it down. And now here I am putting scratch marks with 26 gauge needle on both the sides on the epithelium. So once you have these scratch marks, then you go and stain these scratch marks. So even if your ink fades, these scratch marks, they remain for 2-3 hours and you never lose your reference marks there. So this is the 0 and 180 reference marks which have been made. And this is how we just, again, I use a 26 gauge needle to mark the, so this is a steep axis where toric IOL needs to be aligned. So this is a hydroimplantation technique which I love to use, and it has advantage that there is no OVD left behind which can cause toric IOL rotation. So this irrigation cannula maintains anterior chamber depth nicely in capsular bag. You just put the leading haptic and optic in the bag and put the trailing haptic in capsular bag. So once you have the IOL in the bag, you need to make sure that you have the perfect sizing of the capsular axis, which is very crucial for effective lens position and also for long-term stability of the IOL. So here the overlap was a bit more, so I go ahead and enlarge the axis on one side. And once you have the perfect sizing, you can rotate the IOL to the final desired axis. And you can see it's aligned well to the steep axis where it's needed. And after that, you hydro stitch all the wounds. And make sure that once you take off the speculum, you keep on seeing that there is no rotation of the toric IOL. This finishes the case. So to conclude, now we have devices that calculate total corneal astigmatism, so we can make more precise measurements and we can achieve target emmetropia closely. Thank you very much.
Thank you, Arshil. That was a wonderful talk and very good videos.
Thanks.
So we now welcome the next speaker, Dr. Chitra, who doesn't need any introduction. She's the face of ophthalmology, the scientific forum in almost all places. She's literally married to ophthalmology and an ophthalmologist. So she eats, breathes ophthalmology, and we just love her for her contribution to the ophthalmic scientific work, apart from being a great surgeon. So Dr. Chitra, I mean, we've spoken about now various situations, tried our best to do for a patient, but you know, you will always have this presbyopic IOL group who will have some or the other problem. So whether it's psychological or with their optical issues. So Dr. Chitra is going to talk to us about how to deal with those kind of spectrum of patients. Dr. Chitra.
A very good morning to one and all of you, and thank you, Parul, for those encouraging words. That I think those words make me more mad, and I'm scared of myself nowadays. So my due is to talk on managing unhappy 6/6 patients and in the premium IOL group. Believe me, today it is becoming a rarer problem than what it was before, and we have an overwhelming majority of very happy multifocal patients. And that is some message which I want all of you to take back with you, because there have been studies like the Concerto study wherein 94% of those patients wanted multifocal IOL in the other eye. The Harmony study, 88% wanted multifocal in the other eye. And there was a recent US FDA study wherein they found that 94 to 97% of the patients wanted multifocal in the other eye, compared to only 88% of them who wanted a monofocal. So things are changing, but then we need to address target emmetropia and a happy 6/6 patients. And how do we get there? Because of the paucity of time, I just want you to carefully look at all those 7 C's. And each of those 7 C's need to be addressed if you want your patients to be completely happy patients. And these have definitely an import, and if you address each of them, you're there. And also understand, you're not going to think that you are a perfect surgeon and turn a blind eye to it. Rather, you have to ferret after it and try to address that issue, because there is a problem there if the patient keeps coming back to you. And if you have answered that problem, you have won not just that patient, but that entire family and his friends. But you have to differentiate the problem. Now, is it a kind of a visual disturbance like glare or halos? Is it that the patient was fine initially and later developed the issue? Is it that the vision is disturbed for not for distance but for intermediate or near? These would tell you what is the kind of problem you have. So you need to trace it all the way from ocular surface, the refraction, to the IOL centration, to the PCO, to the macula, to find out where the problem is. But when you see there is a problem, don't be in a hurry to operate on the second eye. When you look at the cornea and the ocular surface, which is the first instant, we are all clear that there are different components of the tear film. Is it aqueous deficiency? Is it evaporative dry eye? Is it a meibomian gland disease? Each of these have to be looked into, and you have to understand that a pre-existent dry eye status could be there in these cataract patients, and some of it could get triggered by the cataract surgery. In fact, 60% of the routine cataract patients in the FACO study had a tear breakup of less than 5 seconds. And again, more than 80% had a positive corneal staining, and all the others which are written there, which tells you that you need to pre-operatively check whether they have a dry eye status. Make it mandatory in all your routine pre-op evaluation. It could be because of the cataract surgery itself, because of the denervation of the corneal nerve endings, because of exposure to microscope light in case your surgery has been long, prolonged phaco time, your preservatives in the post-op drops, some local surface inflammation which has triggered off by the cataract surgery, a goblet cell loss, or a meibomian gland dysfunction. And this was one patient who was fairly fine, had a Shermer's of 10, and believe me, after cataract surgery, she came back with severe dry eye. You had to put her on topical steroid drops, tear substitutes. If you have an access to take a photograph of this meibomian gland dysfunction, you can even explain to the patient of what are the issues which are there, to make her get convinced that this is going to be a temporary issue which you could get her sorted out. So it mandates that dry eye workup is thoroughly done for all these patients. The other aspect is the chronic visual disturbance. It could be for positive dysphotopsia, those glares and halos, negative dysphotopsia, or a temporal shadow, or some of these are entoptic images. Let us understand that multifocal IOLs work on the principles of simultaneous vision. That is, one object is in focus, the other out of focus image is the causative factor. And what happens, that causes the halos to happen. And our visual system is not ready for multifocality. And how much of the light is taken up by the IOL which is being designed, and how much of the light is getting lost. Less of the light is getting lost, better the quality of vision, and that is what the modern IOLs are trying to address. Now, positive dysphotopsia is actually caused by the improvement in the IOL design, by getting a square edge truncated design, and by making the refractive index of these IOLs high to make these IOLs thinner. That causes positive dysphotopsia. Much of it goes with neural adaptation and time, so you need to reassure them, but you need to be sure that there is no other issue like refractive error or ocular surface disease or decentration, and very rarely you need to do an IOL exchange. And the problem is, IOL exchange cannot be done too late either, because what happens is, I don't know why that video is not working. What happens is that it shouldn't become that there is so much of capsular fibrosis that it's difficult to remove the haptic. Why is it not opening? Anyway, if the haptic is stuck and then you have to cut the IOL and prolong your surgery. Negative dysphotopsia is because of a dark shadow which happens, and there's again the similar etiology of high refractive index and the truncated edge design. What happens that the light which gets refracted from the edge of the IOL to the light which gets refracted from the back side of the IOL, there is a Lambertian light scatter, and that kind of a scatter is what causes that negative dysphotopsia. And some of the ways you can deal with it is to do a reverse optic capture, that is, get the optic out of the capsular bag, or you could place a piggyback IOL in the sulcus of 0 power, or rarely even the margin of the rhexis could cause negative dysphotopsia, when rarely you may even have to cut that rhexis margin. Invariably, they could also resolve. So what becomes important is that you need to talk to these patients, try to understand. It could be a centration of the IOL issue. Sometimes the haptic would have been broken. If a patient comes from elsewhere with a decentered IOL, you can never be too sure. You need to ensure during surgery that the rings are well centered and the first and the third Purkinje reflex are in line. You need to look at your angle alpha, but the present day in IOLs have a larger optic size, because of which an angle alpha being even 0.8 doesn't matter. Sometimes if the rhexis is not round, there could be asymmetric back contracture, there could be a zonular weakness, there could be a large angle kappa. Now this was a patient, 60-year-old, who came with that kind of a residual refractive error. Of course, he had needed a toric IOL rotation, but we also found out that he had a zonular weakness and a CTR had to be placed. It goes without saying that if you're on a femtocataract platform, I'm not showing you that video because of the paucity of time. There is the brilliance of the surgery, getting a centered rhexis on the capsular bag, and all the steps of the surgery definitely would take you forward. But again, as was beautifully addressed by Dr. Abhijit, you need to go after the PCO during the surgery. But if PCO is seen, you have to wait for at least 3 months before you do a capsulotomy, and you have to be sure whether it is the PCO which is causing the disturbed vision. In case the patient is so disturbed that you need an IOL exchange, you shouldn't have done a YAG capsulotomy in these eyes, and you to rule out a CME issue in all of these patients. So CME or any of those other macular disorders which has to be looked into, we should be doing an OCT pre-op for all these patients. So essentially, it is prevention. It is not the crazy patient. If you have seen most of the problems, you have to explain to the patient that the IOL power also comes not in 0.25 diopters and 0.5. So there are these issues, and the decision of the IOL exchange need not be the first thing which you do. Sometimes when you even spend some time and talk to the patient, you have won over the patient. And I think you have a range of IOLs. You have low ad IOLs, you have extended depth of focus, you have trifocal IOLs, you have continuous range of vision. You have the whole range. And if you are going to do an optical biometry for your patients, you're going to validate the results, as Dr. Abhijit said, you're going to treat the astigmatism, you're going to choose the right patient. And finally, if the patient has a small residual error, but the patient is happy, let him be. It is rather important that you have a 6/6 minus happy patient and then a 6/6 happy patient, unhappy patient. Thank you very much. There are more slides, but I thought I should stop. Thank you. I hope you all gained something from this talk, and I'm always there to help you outside. Thank you.
Thank you, Chitra ma'am. That was a wonderful talk and a lot of tips for us to handle a unhappy patient. Next speaker is Dr. Gaurav Luthra. He's the owner of Drishti Eye Institute in Dehradun, and he has more than 100 international papers, more than 200 domestic papers, and he's very well known for one of his famous instruction courses, Lord of the Rings, which is like in the top 10.
Also IRS. He'll be talking topic.
Can we take some questions till then?
Dr. Gaurav, are you
Thanks,
ready?
Abhijit. Yeah, I'm set up. Yeah. Thanks, Parul, for inviting me, and it's been an amazing course so far. I'll just try to kind of add my 2 cents to this. Okay. So, what if you have a refractive surprise after a perfect cataract surgery and you worked hard for emetropia and giving the patient a great outcome? First of all, I think I would like to clarify here that the definition of a refractive surprise has changed so much over the years that I've been practicing. In the past we would think that a refractive surprise was, a 1 diopter of a surprise would be probably considered 10 years back. Today, even a 0.25 sets you thinking that where are we going wrong? This is the era of optical biometry and so many other things that are available to us. And even a 0.5 cylinder or more qualifies for a refractive surprise today. So one has to be very careful in what one labels as a refractive surprise. So, and the threshold is even lower for multifocal and presbyopia correcting lenses because the image quality can deteriorate drastically when the refractive error is more than even 0.25 or 0.5. So I sometimes see patients who have received a multifocal implant and astigmatism has not been addressed, and a patient with 0.75 cylinders is coming with a huge amount of dissatisfaction and requires intervention, and that sets me thinking that multifocal IOLs, one has to correct astigmatism even if you're using a 0.25 or a 0.5 cylinder. It needs to be addressed with whichever way you find you're comfortable with. So predisposing factors for refractive surprises are basically extremes of refractive errors, high hyperopia, large myopia, eyes with very steep or flat corneas which may be outliers for biometry, a very shallow anterior chamber depth which will change your ELP, prior history of refractive surgery, and frankly we should all watch out. There are so many post-refractive surgery patients moving around who will not give you a history of refractive surgery, and you may end up with a refractive surprise, and these are the patients who are actually looking for excellent results following cataract surgery. And VR surgery of course adds up to situations where you may get a refractive surprise, and then an irregular cornea and contact lens use, which again, if we are not doing topography for our patients who are undergoing biometry, we may miss patients with contact lens warpage, we may miss patients with inferior steepening, and we may end up with poor results. So whenever using a presbyopia correcting IOL, it's a great idea to look at the a topography as well, and poor ocular surface, as was addressed by Dr. Chitra. So all these, so many reasons for you to end up in a refractive surprise if you're not careful. And then the second thing is setting the right expectations. So when counseling patients for premium IOLs, I think it's very important to let them know that you will not be able to achieve, you will aim to achieve perfection, but you almost never do. And I always tell patients that even with the most expensive lens and the most expensive technology and surgery, we will try to achieve you and bring you to perfection, but we almost never are 100% accurate, and 90% activities may be possible without glasses, but for few things like seeing the very fine print and seeing very fine things in the distance, you will still need glasses. So that kind of lets them know that there may be need for glasses for certain things, and that sets the ball in the right motion. So special at-risk eyes need special counseling. So high-risk patients, post-refractive surgery, other eyes where you are not sure about the biometry, poor ocular media where you may not have a perfect axial length measurement, you have to warn them that there may be possibility of surprises which can be addressed. So, and also of course letting patients know that just in case we have a surprise, we might have to do a second procedure. Now these things have to be subtle, in a subtle way discussed. You don't have to scare patients, otherwise they'll probably not opt for surgery with you. But if you just casually mention it to the patient and the attendant as well, it really helps later on if you've ended up in a refractive surprise. So now once you have a surprise, you have to then make sure that you have all your instrument armamentarium ready. But frankly, today refractive surprises have become less common, even though the bar has been set much higher. Advances in optical biometry and newer formulas have ensured that we get great outcomes. And we have better understanding with artificial intelligence of at-risk eyes. You can be told that this is going to be an outlier, and there's better ways to deal with them as well. So when you do get a refractive surprise, it's best to start tracking your footsteps. Where did you go wrong? Because unless you identify where you went wrong, you will not be able to deal with it correctly. So the issues could be with the errors in planning, or the errors in measurement, or it could be with the errors in execution. So you have to identify where things went wrong, and that's the best way to start looking at how you're going to address it. So error in planning could be so many places. You didn't choose the right lens for the patient based on what his requirements were. You didn't use the right formula. You could have special eyes. You could have errors in data insertion, which often happens, but has been minimized with one and all devices like the optical biometers. And then, of course, you may have missed a previous refractive surgery. For a small correction, you may not be aware that patient actually underwent a surgery. So errors in measurement, of course, unless you're your staff is really good at doing these measurements. Even with an optical biometer, sometimes if you're not looking at the raw data, you may miss patients where there may be errors in topography, in the keratometries, or even with excellent measurements where these machines actually tend to normalize the data, and they use these newer machines can actually use the data in such a way that they're trying to guess it right. So you have to be careful, and I always look back whenever I'm noticing any discrepancies in the two eyes, for example. I will immediately look at the raw data for these patients, and I often find that you can actually look at find the cause there. So just like this, you could have so much difference in the astigmatism in these three gazes, from 0.9 to 1.4 to 1.9 for the same patient, 3 different cylinder measurements based on how the patient is looking. So this becomes very important, and frankly, none of us is sitting in the room where the optical biometry is happening. Of course, the surgery has to be perfect, as must have been explained by Abhijit in his talk, how, when you're dealing with presbyopia correcting lenses, you want absolutely a perfect surgery. Otherwise, you should be mentally prepared for situations which demand, correction. So if you have a refractive surprise, most important thing is to pick it up early. So all patients on day 1 should be checked for if they're possibly having a refractive surprise and marked out, and they should be called back early for a follow-up, so that in case you have to deal with it quickly, you can. And by the 2 weeks visit, which is for us the usual second visit for the patient, you are usually quite sure that if there is a refractive surprise, so don't push it under the carpet. Make sure that you're kind of documenting it and discussing with the patient and seeing how much he's impacted by it, and then getting ready to act on it. And then, of course, you have to try and fix it if the patient is not good. So in presbyopia correcting lenses, there could be surprises for both near and distance, which means you got a refractive surprise for the whole surgery, or you may just have a patient who's not happy with his near vision and happy with the distance vision. So if it's just the near ability where the patient is not happy, then it's not a refractive surprise really, but depends on how you build the expectations and the IOL design which was used. So you can tell the patients to use better illumination, the correct reading distance, you can train them. And you can also look at the fellow eye status, try to give glasses appropriately. Nowadays we try to operate both eyes within a week or 2 of the 2 surgeries, so that patients are much happier and they tend to kind of do much better especially when you're using a presbyopia correcting lens. So the fellow eye status becomes very important, and you can bring hope to the patient that once you do the second eye, they will usually settle down. If you allow this to go on for 6 months, they will usually not come back to you for the second eye surgery and find somebody else. And then, of course, they'll still remain dissatisfied. And binocular vision really helps with these lenses. And of course, when it comes, so it's a huge topic, so I'm running through it, but there is always going to be a debate between how you're going to correct a myopic surprise versus a hyperopic surprise. So there comes the time for decision making. If there is very often in the early days, you may have, you should be, if you have a refractive surprise, you should be looking whether the fellow eye is a myopic or a hyperopic eye, and whether it's a small or a significant surprise. Whether it's a spherical surprise or a toric surprise, of course, monofocal or a multifocal lens, and how symptomatic is the patient, and then of course reassurance that things can be dealt with. Very often it's a capsular block syndrome which is causing this. Even in the early days, you can see this on the OCT very nicely, and if it is that, it can be dealt with in a different way, and this will obviously be very easy to deal with. And then, of course, if we have a refractive surprise, these are all the options which you can do. You can start with giving a small correction. Some patients are actually happy with just a small correction. They don't want a second intervention. Other patients may be dealt with contact lenses, which is rare, But then other things can be dealt with. For example, if it's a toric surprise, you could just do an IOL repositioning within the first 15 days. It usually works really well, but then you have to identify it. We do measurements for all our toric patients on day 1 and day 15 when they turn up for alignment, and then we deal with it if we have to. And then, of course, the other options which are more interventional. So going on, I think I'm going to run out of time, so I'm just trying to see that we can finish this. So I think if you have a wrong IOL, you can do an early IOL exchange or a repositioning if it's a toric IOL. And for this reason, the IOL exchanges have become much more advanced now. We have many techniques for doing IOL exchanges, and if you're using a hydrophobic lens, it's best to do it in time. And rotation can be done very easily. I'll just finish in 10 seconds, Parul, yeah? And rotations can be done very easily for toric IOLs if they are needed. The eye trace is a great device to identify how much rotation is required. And the calculators which are now available online. Another option is to do femto-assisted or manual astigmatic keratotomy. This works really well in multifocal IOLs where there's a small astigmatism, say about 0.75 or something. You can actually correct it without doing much with just astigmatic keratotomy if you know how to do it right. And there are formulas, the Barrett's RX formula, which can be used. So I think the message is clear. The piggyback IOLs, which I prefer to use when there's a patient who's been operated elsewhere and I don't know about the exact surgery which has been done, or in RK operated eyes where you may have a refractive surprise. So the piggyback IOLs have become really good. The ones from Rayner and then now from the CARE group, which have worked extremely well in my hands. So I think I won't show you the surgery, but the last bet is the laser vision correction, which can be done on the surface or with a flap. Both things work really well. Of course, if you want to make a flap, you would have to wait at least 3 months. So I think that covers almost all the situations that can be covered with this in such a short time. And I would like to thank you for that.
Thank you, Dr. Gaurav. That's a very good use of the time that you made. And the main thing which you pointed out is to tell patients, preset it, because we are not saying the presbyopic IOL is to get rid of the glasses. We are saying at the outset that it's to decrease the dependence on glasses, so then any other surprise or, corrective measures can be taken up with in a good way. We have 10 minutes for discussion, so we'll just throw some case-based scenarios when it comes to presbyopic IOLs. And if there's a question from the audience, we surely welcome it. So at the outset, I just realized that out of all the lenses that we showed and discussed, we've not spoken about the Indian lenses and cost effectivity is a situation in India. So Dr. Chitra, would you want to highlight on how Indian IOLs are doing the presbyopic IOLs, and have you used them?
Yeah. I have started definitely incorporated Indian multifocals also into our list. Rather, we do plain Indian multifocals for patients, and if they want laser cataract surgery, we even keep it as one package where they can go in for imported lenses or do laser cataract with Indian multifocal. Patients are brilliantly happy. I am all for panoptic synergy and other lenses. Please do not mistake me, anybody in the audience, but I think the reason why Indian multifocals are also accepted is, it is not just the IOL design which is the critical issue. I feel the critical issue is our getting better knowledge about biometry, using the advanced biometers, getting bang on target values, looking at the dry eye status, understanding that dry eye also has an impact, and the fact that we are able to look into all these extra aspects which I was talking about. I think that has what has made the big difference. And I think unlike earlier days, we should be all for going in for giving a premium surgery, that round rexes and the right biometry and the tear film understanding. Then we would be getting the best results in all multifocals, be it Indian or imported lenses.
So we can look at them confidently. So one of the situations in OPDs is if your patient has only one eye cataract. So we've heard about how presbyopic IOLs need neural adaptation and a bilateral surgery is always better. But many a times you will have a situation where there is only one eye cataract. So Dr. Rishi, would you want to highlight on that if patient has only cataract in one eye, would you still want to go ahead for a presbyopic IOL?
Yeah, why not? In fact, there are many of the patients in my practice don't do cataract for both the eyes within a few weeks. They take 6 months, 1 year, 2 years, and they're quite happy till they do the second eye. So I think it's quite okay. It's just that if you have one of these very young patients who have a unilateral cataract sometimes, and if they're going to be doing night driving, etc. So it's just like how you would select for any regular patient. If they are suitable for a multifocal, we can certainly go ahead.
Yeah,
So one
maybe
eye
we
to
can
okay.
look at extended depth of focus
Yeah.
for these patients.
Yeah.
And now you have these other options, Lucidus and Minivel, which have better optics. So you'll have more of a kind of a monofocal.
So in a
kind
very
of
young
optics.
patient who is an avid night driver, probably you will avoid a diffractive
Yes.
type of a ring,
Yeah.
and you can choose for a EDOF kind of a thing. Another situation is that a patient has already got one eye done multifocal somewhere else, and now he's come for the other eye. So Dr. Abhijit, in that kind of a scenario, he's not happy with the previous eye being multifocal, but he still wants not to wear glasses all the time. So your choice of lens for the other eye, maybe a more forgiving presbyopic lens.
I would first find out which lens is put in that eye. See what Dr. Chitra and Dr. Gaurav talked about. Why is he unhappy? Try to address that to some extent first. So now, if that is not addressable, and then we are going to go ahead with the other eye, yes, we could look at an EDOF in that eye versus maybe a different company trifocal. That also would change the scenario.
Actually, sorry, we can even do one thing. What you can do is, if it is the distant vision is good and the near vision is affected, you can even give, like, I don't know whether Technis +4 is available now, you can give that for the other eye. If the patient is seeing well for distance in that first eye and little defective for near vision, you can give a 0.75 myopia correction. Don't go more than 0.75 between the two eyes, because there is a stereopsis, contrast sensitivity will get affected. But up to 0.75 you can do. So, you know, these ways you can titrate. If it is one batch, largely you should try to keep yourself within a similar material. But sometimes you have chosen one eye for a particular multifocal, you could use the other type for the other eye. You can mix and match. Look at the distance, intermediate, near requirements, and you can do that too.
The only patient whom I would be very careful with is the person who is having halos and glare.
Yeah, that's exactly what I was
So if
going
it
to
is
say.
halos and glare, in that case, I would definitely go in for an EDOF for the other eye or a monofocal after the counseling.
Yes.
So you have to see what is the reason for the unhappiness. If it's halos or glare, then maybe it's worthwhile considering a monofocal optics.
Yeah. And another situation where one eye has many a times now, that because the patients are becoming more aware, they've already got one cataract done, which is a monofocal lens earlier. But now they've heard from their friends and colleagues that, oh, I'm not wearing glasses. Can I do the other eye presbyopic IOL? So what is your take on that?
Absolutely, you can do it, and then you can go back and do a piggyback multifocal to the other eye as well.
Yes.
If you explain to the patient, and I've done that, and it works perfectly well.
Yeah.
So how are does IOCare make the piggyback multifocal as well?
Yes. Yeah. Yes, you can do that.
So if one of your patient has, we know about this negative dysphotopsia, and especially with the IQ platforms, they keep complaining of temporal dark black shadow. So if you've had a patient who's had a presbyopic IOL and is having negative dysphotopsia, would you go ahead and do his other eye? Would you want to do the same lens, change the lens? Would you go for a monofocal in that case? And you waited for 6 months. So in negative dysphotopsia, it's all about neural adaptation. Most of the people do become okay after 3 months, 6 months, but a persistent negative dysphotopsia.
So I would like to take my chances here. So if it's the left eye and it is a negative dysphotopsia, because for some funny reason, these negative dysphotopsias are mostly in the left eye, not in the right eye, I would still go ahead with the same lens and take my chances here, explaining to him that, okay, maybe there is a chance of me doing an IOL exchange if you have the same problem. If it's in the right eye and I have to do the left eye, then I would think twice and maybe change the platform. So instead of going with the IQ platform, I would change over to probably the Zeiss platform.
Right.
Yeah. Also in this eye, which is having persisting dysphotopsia, you can just put again a piggyback lens.
Piggyback, yeah.
That will fix the problem.
Does the rotation of lens help, changing the haptic position, putting it to 3 or 9? I mean, we know, but we don't know whether
if you waited 6 months, I don't know whether that's a good idea.
It's not going to help. The other thing is that, for example, the other situation which I'm coming to cover the distances at all levels is that the companies now have options. For example, Alcon is offering panoptics and Vivity. So somebody who wants distance and near very good, you have panoptics. Somebody who doesn't want to compromise on your distance vision, wants crystal clear, doesn't want halos, and is okay with intermediate and a top-up for reading, probably a Vivity kind of lens would do. So again, just summing up the whole thing, that it all depends on, patient's requirement. So the take-home message is all about, getting the workup right. So it's not just about biometry, but also topos and macular OCT screening to select the right patient, the right lens. Be cognizant of the fact, and to, always we say that under-deliver and under-promise and over-deliver. So thank you very much, speakers, and thank you, audience. It was a wonderful session, and I hope it was benefit to all of us.
Hello.
There's a question, yeah.
May I make a comment?
Yes, sir.
So whenever there is a dysphotopsia, the thing which works very well for me is that I tell them, if you are putting on a specs, at times you can see the frame and the shadow of the frame, but it does not disturb your vision. Same way, because your original lens is of 12 millimeter size, the artificial lens is of 6 millimeter size to keep the incision small. Sometimes you can see the edge, but it will not affect your vision. After that, I never had to do anything for dysphotopsia. So this works very well. And particularly, of course, all of us know that the lens should be placed horizontally and lower inferior temporal side, where the optic-haptic junction will not be able to, he will not be able to see very clear crescent. If you place it vertical, probably there are more chances of dysphotopsia.
So your point is counseling.
Yeah. Counseling, particularly this, because most of them have used the frames, specs, and all of us can see the outline of the frame many times when we are trying to look here and there.
Right.
So this they are able to understand very clearly. Yes, this was a smaller lens, and this is like a frame where you can see the edge, but does not disturb your vision.
It's a wonderful
Thank you.
I'll
Wonderful
try that
tip,
next time, sir. Thank you.
Thank you.
Thank you.